Anyone? So, it seems awful dark all of a sudden.
It really does.
Yeah. So, in the PowerPoint, it includes a little information on orbital cancers. In the book, it does not. So, as usual, I will send you the PowerPoints that we go over this morning. So, we're going to finish up head and neck today, and then, or this morning, and it'll probably take us no more than 45 minutes to an hour. And then we'll start on our next chapter, which is carcinoma of the breast, which will take us at least a couple of weeks to do. I'm hoping to get the breast done today and next week, because as we all know, or you may not know, spring break is the 15th, the 8th. Everybody know that? Okay, I should have known. Yeah, okay, so what we're gonna do, this looks weird to me, see myself on. Anyway. Anyway, what we're gonna do is we're gonna go over the orbit. There are certain ones which, this one in particular, we're not going to spend much time on because retinoblastoma is a pediatric tumor. So we will be doing that in pediatrics, which we'll be doing later in the semester. So primary cancers of the orbit are melanoma, lymphoma, medulloepithelioma, and retinoblastoma, and secondary cancer. So what do we mean by secondary cancers? Metastasis from other sites. It doesn't happen often, but occasionally it will. So the incidence is relatively rare. So 2,400 new cases in the US annually. It includes 1,300 melanomas, so basically half of the cancers of the eye are melanomas. The age range can vary from, there's two actual age ranges. They're what they call bimodal. So youngish people, 25 to 35, and then a group which is 55 to 70. So a younger age group and then an older age group. The younger ones usually are the ones with the melanomas. And the deaths, 250 annually, which is not that bad. So unknown, cause is unknown. Risk factors for melanoma are the risk factors for any melanoma: eye color, inherited melanoma, ocudermal melanocytosis, and I'll explain that in a little bit, sun exposure, and welding. Now, what about eye color?
Lighter colors are higher risk, I thought.
Lighter, yeah, the lighter color, the higher risk, because the lighter the color of the eyes, usually the fairer skin. So if you have blue eyes or green eyes, you tend to have a lighter colored skin or a fairer skin, especially if it happens to go with blonde hair or red hair. There are some obvious exceptions. There are some darker skinned people who have green eyes, but they're usually mixed heritage of some sort or another. So usually it's a fairer skin, which means lighter colored eyes. And the fairer you are, the more you have a risk of melanoma or any skin cancer. Inherited melanoma, well, that stands to reason. Sun exposure, yeah, okay, as it says, melanoma. What could we do to stop melanoma of the eye as far as sun exposure goes? Sunglasses, yeah, especially if you happen to be in Florida or Texas, usually, not this week, but any of the southern states, you should have good sunglasses. And welding. Why welding? The heat?
There's intense brightness that comes from welding.
Yeah, and what's normally used for that though? The shields, okay. So if you happen not to use a shield, then yeah, okay. What else could be from welding? Anybody? What happens if you're welding or somebody's welding something, the sparks coming off? If your eyes are not protected, what happens? You get little things in your eye. You can damage your eye, and that would lead to irritation, which can lead to cancer. Okay, so this ocudermal melanocytosis, thank you. I'm going to minimize this for a minute. Oops. Okay. Go away. Yes. And I'm going to, oh, shoot. I don't have it. Okay, I don't have it on my, anyway, we'll get into it. I've got a beautiful photographs of it, but I left them in my other thumb drive. So oculodermal melanocytosis is a coloring of the white of the eye. It's like a blue colored eye. And it's normal. It's not somebody who's gone and got, heaven help us, tattooed of the eyes. I mean,
That's a real thing.
I've been, but there is, I'll show you a photograph of it maybe after the break. But that's what that is. And I don't think there's photographs of it. I found them on the web.
Are you
So-
born with that?
Yes, yes.
And so why would that cause?
It's just a genetic trait. So it's a genetic risk factor. And lymphoma, immunosuppressant, if you're immunosuppressed. So if you have something that would immunosuppress or suppress your immunity, what would that might be? Say again?
Oh, that's how you get it. If you have immunosuppression, you can get it.
You are in a higher risk,
Like
yes.
taking Humira, or I guess if you're a cancer patient, taking chemotherapy or something?
Okay, if you're, okay. What diseases might what diseases might lead you to be immunosuppressed?
HIV,
HIV, yeah,
rheumatoid arthritis,
yeah,
any autoimmune disease that you're,
yeah, like what?
Crohn's,
Mm-hmm,
myasthenia gravis.
mm-hmm,
I could list
Yeah,
on
okay.
and on for the one of
Yeah.
these.
Okay. Basically, any immunosuppression disease or, the
What is it,
one
the
that,
disease?
the
or is
one
it
that is normal, the one that is most commonly, apart from HIV, is lupus.
Okay.
Which is the one that everybody thinks about.
Or MS, I guess. Is MS also not?
MS can be, yeah.
But is it the disease itself, or is it, I always wonder, because I have to take Humira for my rheumatoid arthritis, and I wonder, is it the Humira that causes the immunosuppression, which puts you at risk, or is it the disease itself, before you start taking that stuff?
Both. Humira is, helps or does not help the immunosuppression. But if you have rheumatoid arthritis, then you are immunosuppressed to start with. If you have osteoarthritis, of course you're not, it's just the rheumatoid arthritis that you are. Okay, so clinical presentation, so symptoms, changes in sight, well that makes sense, right? If you have something in the eye, it would cause changes in sight. Floaters, somebody tell me what a floater is.
Is it like the little white stuff that you see in your vision?
Yeah, there can be little white things or little black things and they tend to, yeah. So the ophthalmologist or the optician will look at you and say, do you have any floaters? And you have, huh? If you've never heard of them. So that's what floaters are. Little things that you see in the corner of your eye that you think you're going nuts, but they really are there. Dark spots, same thing, yeah. Bulging, if your eyes bulge. What else could that be though? Bulging eyes, what?
Or there is a disease that causes that, what is it?
Yeah,
Graves' disease?
which is what?
Graves' disease?
Graves' disease? What is Graves' disease? Where does it come from?
Thyroid?
Thyroid, yeah. If you have what is it called, proptosis, and your eyes bulge, then it is usually a deficiency in the thyroid. And pain. Think about it, if you have something that is causing you problems in the eye, you're going to have pain somewhere along the line. So, patterns of spread, regional lymphatics. Now, we dealt with those in the last semester when we were dealing with, where the heck is it? Surface and sexual anatomy. And we dealt with those when we were dealing with what is it now? One. Okay. So landmarks around the eye, so we have the lymphatics of the head and neck, which is in page 380. You can look at those later. And we'll deal with these in a little bit. Okay, and direct extension. So where would, thinking of the eye, where would direct extension send the cancer? If you have cancer of the orbit and it's going to spread by direct extension, where is it going to spread to? Bone, okay. you're thinking of the orbit itself.
For the brain.
To the brain. How would it get to the brain? What? Pardon? The optic nerve or the optic chiasm, right? So you've got two eyes, the optic nerves come along and they cross. Optic chiasm. So that is a direct route. So where else could it spread to? Think about the eye. Where is it? Where's the closest?
Nose?
Nose. Into the nose. Anywhere else?
Sinuses?
Sinuses. Can go both ways, right? So you have the sinuses that can spread into the orbit, and you have the orbit that can spread into the sinuses. So, surgery. I had to write them down. Okay, iridectomy. Can anybody give me a guess on what iridectomy means?
Removal of the iris.
It's a procedure in eye surgery in which a small, full thickness piece of the iris is removed. It is also called a choliectomy. And usually it's done by lasers. Here's another one. Iridotabeculectomy. So this one is surgery used for glaucoma, so removal of the iris and a small part of the outer section of the eyeball. Yeah. Okay.
Because you have notes right there, and
I will send these to you.
okay, I was like, wait.
No, I will print these out and I'll send them to you, don't worry.
So what was the, iridotrabeculectomy?
Iridotabeculectomy.
Yeah, what was that again?
It, as I said, I'll send these to you. So it's surgery used for eye surgery, for example, a glaucoma. It's a removal of the iris and a small part of the outer section of the eyeball.
Is surgery the first line of defense against treatment? Against the cancer?
Yes, usually. Yeah. Surgery is the most common. So iridocyclectomy is the removal of the iris and the ciliary body. Resection. What does resection mean? Resection anywhere.
Part of whatever it is you're.
Yeah,
you're working on.
Exactly, yeah. Enucleation.
Whole shebang.
Well, not really, no. There's another one that comes to the whole shebang. The enucleation is a surgical removal of the eye and its associated structures. For example, eyelids, leaving muscles and other contents intact. Okay, so they remove the eye, but they leave the musculature and everything intact. Can anybody tell me what the removal of the whole shebang is?
Well, I was going with eyeball, but I'm assuming you're talking about muscles too.
Uh-huh,
There's like 6 or 8 muscles attached to each eyeball, I think.
yep. So the removal of everything is called extenteration. And that's the total removal of the entire globe and other tissues, including muscle, fat, nerves, and eyelids.
I would like to see what that looks like afterwards.
Eyelids. You don't have any eyelids?
Interesting.
I'm not gonna have eyelids.
I meant,
That's basically, you're left with a hole.
so they just put a skin graft there or something, typically? Or do
No.
they do reconstructive surgery?
Sometimes you're just left with a hole. And we can treat that. Sorry? They can do a prosthesis, yeah.
Make it look a little less scary.
Yeah. We have, and I have, and it is done, they can treat the actual hole before the eyelid, before the prosthesis or whatever they're gonna do is there. Okay, chemotherapy. For melanoma, they're doing mitomycin C or 5-FU. They're also doing Rituxan, which is a biologic. And then you have laser therapy, which is something else that I had to look up. Transpupular thermotherapy, commonly known as TTT for obvious reasons. So it is a technique in which a 3mm diode laser beam is induced through the pupil, heats up the tumor to 60 or 65 degrees Fahrenheit for 1 minute. This takes the place of a photocoagulation, which has been abandoned due to the inadequate tumor control. TTT raises tumor to a lower temperature but achieves a greater depth of tumor necrosis. So what is tumor necrosis? Death, yeah, the tumor dies, which is what we want, right? But the fact that you go through the pupils sounds a little weird, but anyway, so that's what that.
You lose the use of that eye.
Yeah. Yeah. For most of these things, you lose the use of the eye, unfortunately. In some cases, they can get away with keeping the eye, but majority of the time, they'll lose the eye. Brachytherapy. Now you can do external beam, but brachytherapy has been allowed for a fair amount of time. So the plaque therapy, if you have a tumor on the eye, wherever it happens to be, you can actually put a brachytherapy plaque on that. The most common one that is used is either I-125 or strontium-89. And the plaque is a semicircular little disc, and it's attached to a long handle. There are two ways to do this. You can actually just place it on for a certain length of time and then take it off. Or they can actually sew it on for a certain length of time, depending on what kind of dose they want to give. That's the two techniques.
What do they use again? What are the two?
It's either iodine 125 or strontium 89.
So, have you ever done one of those?
Yep, several times. In fact, quite a few times.
So how is it administered? Are you in the room or?
Yeah. What happens is that you have this small disc. It's attached to a very long handle, like about yay long. It's the doctor who does it, obviously. And basically they find the tumor, they put it on, it's done by a stopwatch. It's in seconds. So they put the disc onto the tumor, stopwatch is started, 30 or 45 seconds later, they take it off.
And then it goes into some kind of container that,
Yeah, it goes into a small pig. It's like a flask, and it's in a lead pot with a lid, and that's what happens. And the only problem is that depending on where it happens to be, it can be rather difficult to get at it if you're doing it that way. If you're doing, say, a spot on the back of the eye, how do you think we would go about doing that?
External beam.
We can do external beam. In fact, that's probably the most common, to do external beam. But it has been known, and I have seen it done, is that the eye, there's two little muscles that control the eye inside of the eyeball. And they clip these, and I'm glad it's not after lunch. You flip the eye around so that the back of it is facing you. So they clip there's two little muscles, one on this side of the eye and one on this side of the eye. You clip those two, you just take them apart and you turn the eye and you treat that, and then you put the eye back.
I'm assuming that's a once and done treatment, or do they just leave it detached?
They just leave it detached, and it's usually once a week for 3 or 4 weeks.
so if you do that, are you saving the use of the eye by doing that? I don't-
Yes,
So
yeah.
that would be the reason to do
that's correct.
radiation instead
So
of.
if you're doing radiation, you're aiming to save the eye. However,
Retraining those muscles is a whole other thing.
well, you know, you either get the eye taken out or you retrain.
It's not a fun outcome either way.
No, unfortunately, it's
So
not.
what's the prognosis for radiation therapy versus just taking the eye out?
Well, obviously, if they take the eye out, unless it's spread at that point, then the surgery is something like 85%. The radiation therapy is about the same. But it all depends on how early you get it. And unfortunately, with orbital, especially melanomas or rhabdomyosarcoma, the pediatric ones, they tend to be rather late. So, and the dose can vary. It's usually around 4,000, but the dose can vary. So external beam therapy would be, and protons. They're using protons a lot because a lot of these things are young people or children. So proton therapy is very much in vogue for these, and the insurance companies will cover the proton therapy because they're rare. The diseases are rare. And that's one thing that the insurance companies like. So we would do some beams here and there. Unfortunately, a lot of them you cannot save the sight, but you can save the eye. So a good cosmetic response, rather than just take the eye out. You may not save the sight, but you save the eye. So what's the beauty of the protons as opposed to the photon beam? What's the difference between photons or X-rays and protons.
One is a particle, subatomic particle, larger, and one of them is.
So one of the heavy elements is what they're called, the protons, and neutrons, but we don't use neutrons. So as far as treatment goes, what is the difference?
Proton preferred for superficial or closer to the surface
No,
treatment?
you're thinking electrons.
Okay.
So protons, anybody care to guess whether this is a blue or red one? Okay, so. Oh, for heaven's sake, okay, let's put that there, okay, so. Okay.
Is that?
This is my rendition of an eye, okay, so here is your patient. So for photons, for X-rays, we would probably do something like this, which is what they call a wedged pair. So we'd have a wedge here, and we'd have a wedge here. Always thick ends together. The other thing you can do is if you're doing that, take my glasses off. So if you're doing that, what you can actually do is you can angle this one, the lateral one, to an anterior oblique. Why? So instead of going straight lateral, you can go this way. Oh, excuse me, that's not what I wanted. That's a little less. Okay, so instead of that, you can do that. And instead of that, you can do that. So what are we doing? Instead of doing this one, which is going in this way, and this one, which is going in this way, we're doing an oblique this way, and an oblique this way. What are we trying to avoid? Unnecessary treatment to where?
Maybe the other eye?
Yeah, that's exactly what you're doing. This is the bad eye. This is a good eye. There. So what you're trying to do is that if we go straight in this way and straight in this way, this is photons. Okay? So what we're trying to do is, if we go in this way and in this way, what's happening to this area and this area? You're giving treatment. And you really don't want any treatment over this eye, because if you're going to sacrifice, and that's what they call it, sacrifice an eye, you don't want to damage the other one. So that's why we do it this way, so that we're heading out this way and heading out this way, so you're shielding the other eye because you're not coming close to it.
So why is proton beneficial?
I'm just about to tell you.
Sorry.
That's okay. So this is now protons. So let's give them a red face. Okay. Okay. So protons. So the thing about protons is, everybody remember the Bragg peak. What does a Bragg peak do? Or what is it? Somebody give me the definition of the Bragg peak.
I don't remember the official definition. I feel
That's
like
okay, tell me what it is then.
Isn't it depth related, like this maximum dose is delivered at a specific point, that it doesn't go any farther than that?
That's exactly it, yeah. So if we are doing protons, we can deliver a beam here. The Bragg peak can be here, and no other radiation goes any further than this. And the same way, if we do one in here, the Bragg peak comes here, and there's no other radiation comes this way. That's the beauty of protons. And you may say, well, why don't we treat everyone with protons?
Right.
Yeah. Okay. Why don't we treat everyone with protons? Well, the one thing about protons is that our illustrious health insurance people think that protons is still experimental. So there are certain cancers that they will pay for protons. Pediatrics is one. Rare conditions is another. So if you have a rare spinal cancer or a rare eye cancer or something like that, they'll pay for it. If it's prostate or breast or bladder or lung or whatever it happens to be, the insurance companies may not pay for it. And for the most common cancers, IMRT using IGRT is still the standard of care for most common cancers. And that's what the insurance companies look for. It's what is the standard of care.
But proton would be better for,
Not necessarily. There are some cancers which protons are either just as good or maybe slightly worse than X-rays. So it really does depend. But that debate has been going on for 20 years, and I'm sure it's going to go on for another 20 years. You
is
can
it more
have,
expensive to do proton than it is?
it's more expensive to get the equipment and to train people to use the equipment. They still get paid the same amount from the insurance companies as the X-ray people do, or the people who use photons and electrons to treat patients. They get the same amount from the insurance companies. But to set up the proton machines and to train the people on proton, that is more expensive, yes.
It's just really a financial issue.
It is. And unfortunately, that's what happens. So until we get a breakthrough on something, then there'll be this debate going on. And I was at a national conference year before last, and there was a thing going on about protons versus photons. And there was two camps, and they were both radiation oncologists. So one camp was proton oncologists, one camp was photon, electron, normal X-ray oncologists. And I won't say they came to blows, but the discussions were very heated, yes. So I don't think it's going to settle down anytime soon.
So as it stands now, is EBRT more common for the eye, or is it pretty 50-50 with the proton versus X-ray?
EBRT, external beam radiation therapy, actually includes
Proton.
protons.
Okay.
So, yeah,
I always wondered why proton was mostly kids, because I've noticed that, like, a lot of kids get protons. And I didn't
Yeah.
realize-
and that's partly because they tend to have rare diseases. And also the insurance companies pay for the kids much more commonly than they do for adults, because their diseases are rarer. So survival, I will get that to you. So before we start on breast, there's some things that I want to go over with you. Lights are going on. Don't everybody fall asleep yet? Okay. So what we'll do is we will go over these and then we will take a break. So this is on page 606 going to 607. And it says management of symptoms and morbidity. What is morbidity? Can anybody tell me? What is morbidity?
Yeah.
No, that's mortality. What's morbidity? Anybody give me an idea?
What chapter is this?
So like.
Say again?
29, chapter 29.
Yeah, chapter 29, 606, going to 607.
Is morbidities like different classifications and versions of a specific disease
Mor-
or
no.
cancer?
Morbidity is the basic reaction of the body to treatment. So what happens to the body during and after treatment? So if you have a morbidity scale of 1 through 5, for, what have we done so far? Okay, so if you have a morbidity scale 1 through 5 for rectum, morbidity scale of 1 would be change in bowel habits. Morbidity scale of 2 would be unusual diarrhea. Morbidity scale of 3 would be uncontrolled diarrhea. Morbidity scale of 4 would be uncontrolled diarrhea needing hospitalization or external treatment or surgical treatment. So it's usually scaled from 1 to 4. So the amount of dose prescribed to eradicate a cancer ultimately is dependent on healthy tissue tolerance of that dose. Radiosensitivity is the innate sensitivity of cells, tissues, or tumors to radiation. Both healthy and cancer cells are affected by radiation. Cells vary in their expressed sensitivity to radiation. Generally, rapidly dividing cells are more sensitive, for example, mucosa. Non-divided or slowly dividing cells are generally less radiosensitive or radioresistant, for example, muscle cells and neurons. So if you go up to page, or go up to the top of page 607, you'll see the curative radiation doses for head and neck cancers. And below those, the approximate dose tissue response schedule for conventional fractionation. Conventional fractionation, if 5 days a week, once a day, that's what conventional fractionation is. So for nodes, 5,000 centigrade. for any subclinical disease, 5,000 centigrade. What does subclinical disease mean?
Something you can't see
Mm-hmm.
presentation.
Right, that's right. So T1 lesion, which is small, 6,000 to 6,005 centigrade. T2 lesion, slightly bigger, 6,500 to 7,000 centigrade. When you go up to T3 or T4 lesion, it's 7,000 to 7,005. To actually curative dose. You want to curative, you want to cure this cancer or give them long-term survival. To do that for a stage 2, stage 3 or 4 lesion, you have to up the dose. So here is the approximate dose tissue response. So dry mouth, it happens around 2,000 centigrade. Erythema, which is what?
Redness.
Redness, happens around or can start around 2,000 centigrade. This is the dose that you start. Problem with brachial plexus is 5,500. Spinal cord, 4,500. Lermit's sign. Should look that one up. I'll look that up and let you know. Mandible, teeth, and gums, 5,000 to 6,000. Mucositis, it starts at about 3,000. Now these are dependent on the patient. Some people don't get them at 3,000. If your patient doesn't get mucositis at 3,000, don't worry about it. They may start it earlier, they may start it later. It depends entirely on the patient. Problem with the ears, 4,000. Cataracts, 500 to 1,000. That's why you have to always try and avoid the eye. Although cataracts now are easily fixed, but still. Dry eye, 4,000. Optic nerve, 5,000. Retina, 5,000. Laryngitis, 5,000. Trismus. What's trismus? This is something we haven't actually discussed. Anybody know what trismus is without looking it up on YouTube or Google or whatever you have to have there? Trismus. If you're treating the mouth, you have a problem with dry mouth, you have a problem with sore mouth, a problem with maybe swallowing because it's going through the mouth. Trismus is being unable to open your mouth fully. So some patients will, when they're finished their treatment or halfway through their treatment, they'll find out that they can only open their mouth this much. That's what trismus is. Unable to open your mouth fully.
What causes that, just inflammation?
It's the treatment effect on the mouth, the soft tissues, and sometimes the bone and the musculature. So basically they work, this is where perhaps a speech therapist comes in and they can work with them and help them with the movement of their mouth again. So, dysphagia. So we're going now to the top of the second column here. Dysphagia. Difficulty swallowing and issues regarding normal functioning of the throat is common among head and neck cancer patients as they undergo RT. Speech pathologists are instrumental in working with these patients to maintain or improve swallowing physiology and function. Periodontal disease and caries. What did we say about dental checkups before the patient starts treatment?
Wanted to have it done before any kind of treatment, so that.
Exactly.
Afterwards.
Exactly. Because once we start treatment, it can affect the teeth and the gums. So because healing is poor after treatment, extractions of carious teeth after RT are not recommended. Aggressive extractions after high doses can lead to osteonecrosis. The teeth should be extracted before RT if the patient has carious teeth. What is caries?
Okay,
Pardon?
okay,
Decay, okay. Anything else? If somebody needs fillings, for example, that could also be there. So nutrition, we've gone over nutrition. Both tumor and the treatment side effects such as mucositis from both chemo and RT may contribute to the problem of bad nutrition. Placement of a G-tube or a nasogastric feeding tube may be necessary to maintain adequate nutrition. So mucositis and stomatitis. Inflammation in the oral mucous membranes with edema and tenderness can occur. The membrane can slough off and leave a friable, painful, ulcerated surface. Xerostomia. What's xerostomia?
Dry mouth.
Dry mouth, yeah. So it can occur after about 1,000 centigrades, depending on your patient. And diminished long salivary function as doses as low as 2,000. Normally, if they have, it can be permanent, approximately 4,500 to 5,000. So you may not have saliva. So what do you do? If you have to treat that area with the salivary glands, or you're treating the salivary glands, and it turns out that, oops, you just destroyed the salivary glands. What do? You've no saliva left. Is there anything we can do? You can carry a bottle of water around, but everybody does that anyway. There are some medications which can, and there's also some medications that can help with dry mouth. There's also some mouthwashes that can help with the dry mouth as well.
if you're doing one side, you're treating one side of the face, is the other, is,
The other salivary gland is good.
so you,
But if you have to treat both salivary glands, then, yeah, okay. So cataract formation. This is the most sensitive, radiosensitive tissue in the head and neck area, is the lens. So if you have to treat around the eye, the physicians will sometimes shield the lens, which means putting a little piece of shielding above the patient on a tray to shield the lens, and just to shield the lens. So the patient is instructed, as soon as we tell them to keep their eye open, and look straight up. And that's part of the treatment, because if they close their eyes, then their lens will not be on the shielding. Lacrimal glands. Irradiation of the lacrimal gland may cause a dry, painful eye. Severe dry eye syndrome has been reported in 100% of patients receiving more than 5,700 centigrade to that area, obviously. Obstruction to the tear duct, which is rare and usually associated with tumor involvement of the lacrimal duct. Taste changes. This is something that most patients complain of. Taste changes. They may not be able to taste sweet things anymore. They may not be able to taste sour things anymore. It depends entirely on the patient, but there will be taste changes. You heard my story about the little old guy saying everything tastes like sawdust. Yeah, well that's basically, during treatment sometimes the taste goes all away completely. It will come back, but it may change when it comes back. And of course then there's skin reaction. And the skin reaction can be something pretty significant, especially if they're also in chemotherapy, which acts as a what? Pardon? A radiosensitizer, yeah. So it says here, there's a little thing that says, okay, forget about that for the moment. Recommended oral hygiene program for the patient. Clean teeth and brush gums after meals, usually with a very soft toothbrush. Use fluoride toothpaste or fluoride rinses daily. Floss daily. Rinse the mouth with soda, salt, and a baking soda solution. See a dentist regularly, etc., etc., etc. So this is a normal oral hygiene program, not for the patient. Avoid the following: spicy hot foods, coarse or raw vegetables, dry crackers, chips, and nuts. Okay. Smoking, chewing tobacco or alcohol, sugary snacks. Commercial mouthwash that contains alcohol because it dries the mouth, and cold foods and drinks. So skin care. So if we have a patient on treatment for the mouth, we would not be recommending them to brush their gums and teeth after every meal. We would give them a particular type of mouthwash. We'd also give them what they call touthettes, which are things like on an orange stick, and it's a little, they're usually pink. It's a little sponge on the top. And you wet that, and then they just go over it they go over their mouth and gums with that touthette. No commercial toothpaste, because that can irritate. No commercial mouthwash, because that contains alcohol and can irritate. Lots of water, lots of fluids, no alcohol. So skin care. We want them to keep the skin as dry as possible. If they're washing, then wash with a mild soap, preferably a baby soap, and pat dry, do not rub dry, because the skin is going to get irritated and you don't want any more added friction to it. No perfumes or aftershave for the guys, because again, most of them have alcohol, in fact, all of them have alcohol, and it can irritate the skin. As far as shaving for the guys, electric razor. No straight razors or open razors. Safety razors are what they're called these days. Everybody knows what I mean, the difference between an open razor and a straight razor? Okay, so what do the guys use if they don't use an electric razor?
The plastic disposable ones?
Yeah, or the ones that come up with, Harry's or Gillette or whatever they happen to be. They're disposable, right? They're what they call safety razors, these are, okay? But if anybody has a grandfather who's old enough that he's still using a straight razor, you've seen those, the ones that they strop with, yeah, definitely not. Anything other than an electric razor, we would not want them to use. And that's because we don't want any added friction. Although the electric razor does add friction, but it's least, rather than either the safety razor or the straight razors.
Do they ever have lack of regrowth of facial hair from treatment up here?
Depending on the amount of dose, yes, they can. If you're only treating part of the face, you'll find that that area may not grow back, or it may grow very fine like baby hair, like fuzz. But yeah, it may not grow back at all, depending on the amount of dose that we give. Do not use aftershave lotion or perfumes. If we're using, it says avoid tight-fitting collars. If you have somebody who is working and they have to wear a collar and tie, that could be difficult for them, especially if you're treating this area. So if they can get away with it, leave the collar open. Or have a looser collar and tie. The other thing is keep the area out of the sun and or the wind, because you want to stop any added friction. And the sun on your face will add friction. The wind can add friction. The cold, now we're not hopefully gonna see cold here, but if you're in the northern climes, yeah, you have to be very careful of the cold and the wind, because it can add to the side effects. Okay, so let's take a break. We'll be back at, so this is 5 past, back at 25 after, gives you 20 minutes, and then we'll start on breast cancer. Okay.
So she's leaving. Stop.
Stop.
It's just that little cute how you say it.
The nacho ones. They're so good.
This girl is so stupid. We were in the bank together, right? And our boss, he was MPA, that's what we called him, MPA. And I guess when they transferred to a different area, they had to transfer to the same place. Not like their
melanocytosis.
Your screen is, oh, there it goes.
Yeah. So you can see it's sort of bluish black. And there's another one that you can see it a little bit. This is less.
It's like an ink spill.
So that's basically what I was talking about. Difficult to figure it out when you don't know what I'm talking about. So anyway, so let's look at carcinoma of the breast.
Yeah.
It is chapter 34, and we will be going through, I just want to go through a few bits and pieces here before we start. So, incidence. What is the most common risk factor for breast cancer? Common risk factor.
Gender.
Yeah, being female.
Yeah.
Yeah, unfortunately, being female, yeah. Although the men can get breast cancer. Does anybody know the incidence of breast cancer at the moment, female breast cancer?
I feel like every site says something different.
Yeah.
but-
It's usually 1 in 8. Used to be, several years ago, it was 1 in 9. Now it's 1 in 8. And 1% of breast cancers are male. So risk factors is gender. Breast cancers occur 100 times more in women than in men. 1% of the malignancies in men, or are men. Age. What is the age? When do we start doing mammograms, ladies?
40?
Mm-hmm. Does that mean that breast cancer starts at 40? Really? Why not? So why 40? Why would the American Cancer Society stipulate that 40 was the cutoff.
You have a greater chance as you age.
Say, say again?
You have a greater chance of getting it as you get older.
Yeah. As you get older, your risk increases. So they had to put the cutoff date somewhere. So they put it at 40. In Canada, it used to be 50. Now they've dropped it to 40 as well. So breast cancer, between 2012 and 2014, the probability of breast cancer development in American women at the age of 40 was 1 in 68. At the age of 50, it was 1 in 43. The age of 60, it's 1 in 29. The age of 70, it's 1 in 25. So the lifetime risk is 1 in 8. So you can basically have ladies from any age. The youngest patient I ever treated for breast cancer was a young lady of 22. So, yeah. So race, what would you think?
Caucasian.
Caucasian? More common? In the US, yes. However, unfortunately, the black population tend to be more advanced when they are diagnosed. Slightly higher in white versus black. So white, it's not that much different actually, guys. In white, women is 122 to 100,000 versus 117 per 100,000. So it's not that different. Despite this, black women tend to present with more advanced disease and have a higher mortality rate. Furthermore, there's a growing body of evidence to suggest different causes of carcinogenesis between patients of different genetic backgrounds. Weight, they're saying, among post-menopausal women, which is ages what? What age would you say would be post-menopausal?
After 50.
Yeah, okay. Depending on, obviously, menopause can range from anything from 45 to 60. So, yeah. Or 50.
Are you kidding me?
No, I'm not kidding you.
You don't want to have a baby at 55?
I went through it at 45, so.
Yeah.
I didn't know I was like at the beginning of the spectrum.
Oh, yeah.
Wow, 60.
Yeah, 60.
No,
Yeah.
I wouldn't know.
Actually,
I can't imagine at 40, it was like.
yeah, when I was working in El Paso, for a while my husband worked on the ambulance, and he got called to a house in El Paso, and there was a lady going into labor, and he delivered the baby in the ambulance, but that's beside the point. She was 65.
Wow.
And this was a natural birth. No,
That makes me tired.
Did she
just
die?
thinking about
I
it.
know.
Pardon?
Did she live? Did she live?
oh yeah,
Holy shit.
yeah. But 65, and this was her 8th kid,
Oh
my God.
8th child.
Mm-mm.
But, and that no,
The real question is, was the baby?
no IVF or anything, just natural. And it took me a while to figure out if he was joking with me or not, but no, it was true, yeah. Yeah, she was actually in the paper.
Imagine
I
being,
bet.
imagine being close to 90 when your child graduates high school.
Yeah,
No.
I know. Yeah, so anyway, so that's why I say menopause can stretch quite a while.
Wow.
Yeah, so postmenopausal usually is put around 55-ish, there or thereabouts, so.
I had 2 kids, got 2 shots. I had 2 kids, got 2 seconds.
So, everybody knows that there is a genetic factor to breast cancer. What is that genetic factor called? Thanks to Angelina Jolie, everybody should know what it is.
BRCA gene,
BRCA what?
BRCA1. Isn't there BRCA1 and BRCA2?
BRCA1 and BRCA2, yeah. So not only does BRCA1 and BRCA2 affect the genetic predisposition for patients in breast cancer, but also in ovarian cancer. So, yeah. So a woman with, and the other thing is that if you discount BRCA1 and BRCA2, there's also a family history of breast cancer. So if you have a first-degree relative with breast cancer, or who has had breast cancer, then you are more susceptible to getting breast cancer. So what would be a first-degree relative? Aunt or sister, yeah. Mother or sister. So a woman with 2 first-degree relatives with breast cancer has a 3-fold risk of development of breast cancer compared with a woman with no affected first-degree relatives. In addition, the age of diagnosis of the affected first-degree relative also influences the woman's breast cancer risk. First-degree relative diagnosed before the age of 30 confers a threefold risk of developing breast cancer. Whereas if diagnosed after 60, the risk increases only 1.5-fold. So if you have a mother who had breast cancer at 30, then your risk is 3 times as much. If she didn't get breast cancer until she was 60, it was only 1.5 times as much. But only 5 to 6% of all breast cancers are directly attributable to mutations, for example, BRCA1 and BRCA2. Obviously, lifestyle has been coming into effect here. So tobacco use, alcohol intake, night shift work as a possible carcinogen. They haven't actually studied it yet, or they haven't got proof yet. And then, of course, radiation exposure. So, think back to your anatomy, guys. What does the breast consist of?
Adipose tissue.
Mm-hmm. And? Vascular. Okay. Somebody said gland. Did I hear gland? Glandular tissue. Yeah. So it's basically fat and glands. And that's basically what it is. So if you look on the page 711, you will see the musculature and the breast. So you have adipose tissue, you have suspensory ligaments that basically hold up the breast. You have ducts, and they all go to the nipple. And you can see basically the same thing on the diagram behind you there, or beside you there. And you can also see the glands, the lymphatic system there. Primarily though, if you have a tumor in the upper outer quadrant or the inner outer quadrant, or excuse me, the upper outer quadrant and the lower outer quadrant, the lymphatic drainage goes to the axilla. If you have a tumor in the inner upper or inner lower quadrant, it goes to the internal mammary chain, which is the middle here. Okay, so that being said, let me get so let's see. Okay, so this is just a review. Whoops, all right, that's just a review. Let me just put the main lights off. So, the breast. So you have lymph nodes, you have the areola, you have blood vessels, you have fatty tissue, you have ducts, and you have lobules. What are these? Pardon? Say again, I missed that. Ribs, yeah, the end of the ribs. These are the end of the ribs. So it's conical in shape. So if you do it in a clock, this is superior lateral, inferior lateral, or upper outer, lower outer, superior medial, and inferior medial, or inner upper and inner lower. And then you have the areola and the nipple, and then you have the axillary tail. This is something that you have to remember. Lies in the superficial fascia, the front of the chest, that has a base, an apex, and a tail. And its base extends from the 2nd to the 6th rib. Depends on how big you happen to be, and also if you are, how shall I put this politely? I can't even think of something polite to say, but if your Cooper's ligament is nice and firm, and then you would be nice and firm. If it's not, then you would sag a little bit. So that's why they say the 2nd to the 10th rib, the 6th rib. It extends from the sternum to the mid-axillary line laterally, and it has no capsule. You have this axillary tail. There's another name for it. It's called the tail of Spence, and it goes right into the axilla. That's also part of the breast tissue. So here's the clavicle, the ribs, and the, suspensory ligament. Okay, suspensory ligament here, or the Cooper's ligament as it's called. These are the glands and the nodules, the glands and the lobules, and the fat. The yellow is the fat. And again, it depends on how big you happen to be, how much fat you have. So the second rib to the sixth rib. So here is the ducts and the lobules. 2/3 of its base lies on the pectoralis major muscle. And its superior lateral part sends a process to the axilla called the axillary tail or axillary process or the tail of Spence. These are all lymph nodes into the axilla. So you can see if you have a tumor here, it will go to right here. Pectoralis major. And there's your lower part of the breast and the tail of Spence going into the axilla. And you've got blood vessels, obviously, and lymphatics. The nipple lies approximately the fourth intercostal space. And again, depends on the anatomy of the breast, actually where it lies. In the male, that's where it lies. The female, it's approximate. Mammary gland, so they have fat lobules, areola, the nipple, the ducts, the lobules or their lactating ducts, and the pectoralis fascia, and the spaces between the ribs. Separated from the deep fascia covering the underlying muscles by a layer of loose areolar tissue. Cooper's ligament. Cooper's ligament here. To connect the skin with the deep fascia of the pectoralis major. If you're older and your ligaments are not as tight as they used to be, then you have what is commonly termed Cooper's droop. The ligament is lax, so that's what happens. So each of these lobules, and this is where the cancer usually arrives. You have either ductal carcinoma or you have lobular carcinoma. Ductal carcinoma is the most common. Lobular is not far behind it, but it's still less common. And here's your arterial supply. Don't have to worry too much about that these days, but as far as we're concerned, we're not too worried about the arteries or the veins. We're more worried about the lymphatic drainage. But here we go. So the pectoral anterior group lies along the pectoralis major.
Having quite a party over there.
Next door, yeah. Subscapular group, brachial group, central group, apical group, and subclavian trunk group. So you have all of these nodes, you can see them here, and you can see them here. So depending on where your lesion is, it can vary. And I'll send you this one here, so. Infiltration of the Cooper's ligaments of Cooper by breast cancer leads to its shortening, giving a peau d'orange appearance of the breast. So this is what is called peau d'orange. I have some more photographs of that I'll show you in a couple of minutes. So what does peau d'orange mean?
Skin of an arm.
Yeah, and if you ignore the nipple,
Are those hair follicles?
no. If you ignore that, it's indentation skin. Doesn't it look like the skin of an orange there? I actually have a better view of it. And the mammary ridge. Several mammary chains. So in animals, if you've ever seen a dog or a cat, they have lots of little nipples down there. That's where it comes from. Okay, so let me show you these photographs just so that you can see what I was talking about. Okay, so this is a mammogram. Let me see if I can make it available. It's not doing it. No, it's not going to do it for me. Okay. So this is, you're looking at the mammogram here. This is the cancer. Difficult to see, it's right there. This is a proved cancer on ultrasound. You can see it right there. It is not a round one, it's very irregular, which gives you an idea that it is cancer, and it's not. It's why we do ultrasound if the mammogram is suspicious. It can tell whether it is just a breast lump or it is actually malignant. Okay, let me just take that away. No, thank you. Okay. This one is what they call cutaneous breast cancer. It is a breast cancer which has spread to the skin. So all of these little lumps are breast cancers which have eroded out of the skin. I'll leave that one for a little bit. Inflammatory breast cancer. This is a type of breast cancer which is very difficult to treat. It is very hard to diagnose somewhat because most physicians who are not oncologists, if you go to your primary care physician with this, they're going to say that you have an infection because the skin is hot to the touch and it looks like an infection. It is not. It is inflammatory breast cancer, and it is very thankfully rare, but it is very, very aggressive.
My aunt had it.
It is very aggressive. Here's another one. That one is more likely to be taken seriously.
I mean, does that come up so fast that?
It does.
I was gonna say.
It does. A normal inflammatory breast cancer, normally breast cancers, any kind of cancer grows slowly. The inflammatory breast cancer is weeks, not months or years. So this is an MRI. So you can see, you can actually see them beautifully. One there, one there. And then that begs the question, why don't we use the MRI for everybody? Why don't we? Tell me, why don't we use an MRI for screening?
Because of the metal issue with the magnetic.
Okay. A little more down to earth than that one, though. You're right. Some part of the population can't have an MRI because they have a pacemaker or they have metal in their body or they have whatever. Is everyone in the US able to get an MRI? No. Is it less or more expensive than a mammogram? It's more expensive, much, much more. So the idea behind a screening tool is what? We did this last semester. What are the conditions for a screening tool?
Cost effective.
Pardon?
Cost effective.
Cost effective, yeah,
Accessible,
accessible,
accuracy.
accuracy. What else? Those are the three big ones. So is it cost effective for an MRI? No. Is it accessible to everybody? No. And it certainly isn't more expensive or less expensive than a mammogram. The only people who may be acceptable for this is young women with very dense breasts. It has been known over the last 20 years that mammograms are less effective in finding tumors in ladies, young ladies especially, with dense breasts. Sorry?
Like young ladies without kids.
Yeah.
Does it happen often that you would have a tumor in both breasts like that?
Not very often, but it does happen, yeah. It does happen. I've treated quite a few.
Right, I do.
It's like my grandma had it in one, and then the next year she had it in the other, in the same spot, but like
Yeah, yeah.
on both sides.
So this is more what you see. This is clinical peau orange. This is what you see on the breast.
So is that each one of those little dots, is that suspensory, is?
No, it's not, it's just the skin getting puckered. It's just the skin getting pulled.
So is it getting pulled by those ligaments? Or
No, it's getting pulled by the cancer.
So only in the area where the cancer is, so the whole breast would look like that?
The
Just
whole
that-
breast can look like that, yes. In fact, the whole breast usually looks like that if you have peau orange. No. This one is just lumps and bumps.
They don't play around with those biopsies, they take big chunks.
They have to. They have to because they have to make sure they get a big one. So, and it's not quite lunchtime yet, so, my apologies in advance for this,
It can be lunchtime.
but I'm gonna show you some not so pretty pictures.
Oh, no. Oh, no.
It makes you hurt.
So this is what we call fungating breast. Once you see it and smell it, you'll never, ever forget it. This is a PET scan. And this is huge.
That's breast. That's a breast?
That's
right
a breast,
spot?
yes.
Oh my gosh.
And this is actually after she's been on treatment for a while, so it has reduced somewhat.
So is that pretty rare?
It is getting rare now, yeah. This is also a fungating breast. And we still see them, ladies.
What causes like something like that?
Pardon?
What causes something like that?
Somebody ignoring it for a long
Somebody
time?
ignoring it for years.
I'll have it checked eventually.
Yeah.
No way.
It's fear, guys, it's fear. They know there's something wrong, they don't want to be told, so they ignore it.
You can see the puckering of the skin around that one. The
Yeah.
dimpling and stuff.
Yeah, this is way past peau d'orange. This is the tumor coming out through the skin. And this is not extreme. This one is extreme.
Oh. So when it gets that bad, what's the treatment, like, option?
Yeah, that whole thing's gotta go.
Something like this, we used to do, and they still do occasionally, is what is called a toilet mastectomy. A toilet
Okay.
mastectomy. Basically, the reason why it's called a toilet mastectomy is you're cleaning it up, and you're going to take as much as possible of this fungating area out. The surgeons are going to go in and take as much as they can out, because remember, this is outside of the breast. So it comes from inside to the outside, that basically bursts through the skin.
Like fungus. I mean, like a mushroom would come up.
Yeah. And if you leave it long enough, it'll just burst. And these,
hurt.
How would they even wear clothes with something like that? That'd be.
Wouldn't you want to go to the doctor because of the pain?
The
No.
nerves could be affected, I would think, and you might not feel it as much on the outside if you've got nerve damage.
no, the problem is that it doesn't hurt.
It looks like.
It just, it feels strange. It looks evil. It stinks. I'm not even saying it smells, it stinks. And the problem is that it's fear. And I'll tell you a story, true story. I was in Canada and I came home on vacation. And my mother says, your Aunt Nettie, my father's sister, one of my father's sisters, is in hospital. I said, oh, what's wrong with her? And she says, she's got breast cancer. And I said, what, mother? She's got breast cancer. I said, why are you whispering? You know, we're in the house on our own, you know. Oh, she's of an age where you didn't mention cancer. So anyway, she was actually in a hospital where I trained. So I went up to the local hospital, got there just as visiting time was finishing, and I met my cousin. his mother was the aunt, and said, how's your mom? I said, oh, she's okay, she's doing okay. So I went in to see her. And as soon as I opened the door, I thought, and it's the smell that hits you. And I thought, I've smelled that, I've smelled before. So I sat down and I talked to her and I said, okay, Aunt Nettie, how long have you had this? Oh, a couple of weeks. And I said, yeah, right, well, a couple of years. I said, well, why didn't you tell somebody? I was scared. And yeah, I mean, this is the normal. So I went to the charge nurse. In Britain, the charge nurses are called sisters. It's not a religious thing, it's just tradition. So I said to the sister, so I told her who I was and what I was. And I said, you know, this is all pre-HIPAA, just so that you know. Can I look at her chart? And she says, oh, sure, here. As I said, it's pre-HIPAA.
Yeah.
So I looked at her chart and I said, so she's having radiation. Yeah, just to see if we can clean it up a little bit and make her more comfortable. Okay, so she died about 3 months later. But there was photographs in the chart. And it was similar to the second one that you saw there. And I thought, you know, all she had to do was call me or write me a letter or tell my mother and she would call, but no. She was scared.
So what made her eventually go in after years of it being there? Like, what was the final straw that made her actually go in?
Her daughter-in-law dragged her into the hospital, into the doctor's office, and said, you're going, and if you don't come peacefully, we'll send an ambulance for you and they will take you in, and I will make sure that they take you in. And that's how she got into hospital. So, yeah. So it's very much, thank goodness it is, we don't see it very often anymore. Occasionally we do, but not very often anymore. Except in, shall we say, those religious, I'm trying not to say cults. Those religious people who don't believe in hospitals or surgical intervention. So anyway, it's still, in parts of the world, it's still a stigma. It really is, it's still a stigma. So let's get started. Okay. Okay, so we've done that, we've done that, we've done that. Okay. Okay. So, factors affecting the breast. Hormones. We all know when we menstruate what happens to the breast.
It gets sore.
It gets sore. It swells. And it gets even more sore. Age, we've mentioned. Menstruation and menopause. It has been said that if you have a high risk, if you start menses early and menopause late, then you're at a high risk. So lymphatics, axillary, internal mammary, subclavian, and supraclavicular. So, axillary is here. Internal mammary is right here. on each side of the sternum. Subclavian is where, would you say? Subclavian, below the clavicle. And supraclavicular is above the clavicle. Yeah. Okay, so incidence, 178,500 new cases. $62,000 new cases of carcinoma in situ. The most common type of tumor is ductal carcinoma in situ, or DCIS. We do treat those. Deaths, 40,000 annually. And worldwide, unfortunately, breast cancer tends to be increasing. And it is a stigma in some parts of the world still. In parts of Africa, for example, that and cervical cancer are very much stigmatized. So, BRCA. BRCA genes. Risk factor, obviously, gender, aging, genetics. All of those are different types of genes. P53 is a tumor suppressor gene, which if it gets damaged, then the tumor suppressing part of it doesn't exist, so the tumor continues to grow. So family history. 2 or more relatives with breast or ovarian cancer, because breast and ovarian cancer are both hormone driven. Relatives with both breast or ovarian cancer. 1 or more relatives with 2 cancers. Male relative with breast cancer. Family history of breast or ovarian cancer and Ashkenazi Jewish heritage. Has anybody heard of Ashkenazi Jewish? Tell me what it is. Or have you just heard of it?
What it is, I had a friend who had a bloodline of Ashkenazi, and her mother, Jewish, and her mother did die from breast cancer.
Yeah.
Very quickly.
Yeah. Ashkenazi were, or are, it started off as a small group of Jewish people in the Central Asia area. And they were a very small community, so they intermarried quite a bit. So any of the genetic diseases that were there became more so because they were enclosed. And as they migrated, they took their genetic predispositions with them. I've got a paper that I'll send you on the Ashkenazi Jewish ladies. And the family history of diseases associated with hereditary breast cancer. If you consider that a lifetime risk is 1 in 8 for most people, I believe the Ashkenazi ladies have a 1 in 3. It's very, very bad. So what happens if you find out that you have an Ashkenazi heritage, or you have a BRCA1 or BRCA2 gene? Is there anything you can do?
Start screening early.
Start screening early, yeah. How early?
Maybe 20.
Or as early as you can persuade a physician to do it, yeah. Normally it's 40, the age of 40 for a normal risk person, but if you have that type of risk, then you start early. What else can you do?
The mastectomy.
Just one mastectomy?
Well,
Both, bilateral mastectomies. Okay. Anything else? Because ovarian cancer is also hormone driven, then most people might choose to have bilateral mastectomies and bilateral oophorectomies, as did Angelina Jolie.
Remove the ovaries instead of doing the mastectomy as well?
No,
You have to
No.
do both.
have to do, well, you would more likely do one first. You'd more likely do the bilateral mastectomy first. And then the oophorectomies take away the hormones permanently. Because if you have no more breast tissue, then the chances of you getting breast cancer are remote by then. But you still have the hormone effect that can lead you to ovarian cancer. So that would be the second line of defense. The mastectomy would be first, the oophorectomy would be second. And they're doing wonderful things with reconstruction these days. So a personal history of breast cancer, obviously, and race again, and a history of abnormal breast biopsies. So if you are one of these people who keeps getting breast cysts, then you might want to think about getting screened earlier. So non-proliferative lesions, which are the breast cysts. Proliferative lesions without atypia, which means that they're still benign. And atypia means that they're turning malignant. Okay. And radiation is another risk. Menstrual history, again, that means that did you start menses early? When did you finish? When did you go through menopause, if you have gone through menopause? Diacetyl-B-strol. Has anyone heard of that? No? Diacetyl-B-strol was a drug which was given in the 1950s or 60s, I believe, to pregnant women. And it didn't cause any problems to them, but they found out that their female offsprings have a high risk of breast cancer. So if your mother was given it, the mother's okay, but you would have a higher risk of breast cancer. Nulliparity. What does that mean? Nulliparity.
Not having had children.
Not having had children, yeah. And oral contraceptives. So, hormone replacement therapy, combination with estrogen replacement therapy. So, you have a hormone replacement therapy. It was all the rage maybe 15 years ago, still is in some cases. What is it though? Hormone replacement therapy. Who gets it?
Usually women who've had like a total hysterectomy, or at least their ovaries.
No, no. It's ladies who are going through menopause. And what are the symptoms of menopause? Yeah, and in some cases, sometimes debilitating hot flashes. What else? Irregular bleeding. Changes in your demeanor. You get grumpy. And sometimes it really is debilitating for some ladies. So they put them on this hormone replacement therapy so that it eases the side effects.
So if you have your ovaries removed, they don't give you anything to replace those hormones?
No,
Oh, that seems like a
because
disaster waiting to happen.
because they found that hormone replacement therapy is a risk factor for breast cancer. You just go through menopause. If you have your hormones, if you have your ovaries taken away, you go through menopause. For some people, it can be disaster. For other people, you have a little hot flash, you get grumpy and what have you, but that's it, you know. So you can survive. Honest, you can survive. Breastfeeding. Alcohol. Obesity. Physical activity. So obviously, the lack of physical activity, the lack of breastfeeding, because if you're nulliparity, you breastfeed. And overweight as usual. Unproven, here we go. Antiperspirants, underwire bras, abortion, breast implants, pollution, smoking or secondhand smoke, and night work. The night work and the smoking, they've done some research. And smoking is bad for everybody, let's put it this way. Smoking is bad for everybody. And secondhand smoke is not good for everybody either. But night work is still a little controversial. They did a series of research on nurses who work constant nights. And they said that those nurses have more breast cancers than their daytime colleagues. But there's only been a small section of that done. So it hasn't actually been peer reviewed yet. So, as far as antiperspirants, underwire bras, breast implants, pollution may have something to do with it since smoking has. But then pollution has a risk for everybody. So. Breast implants, there is one particular cancer which is known to be attributed to one type of breast implant. But it's a very rare one, and it is not a common one. But the normal breast implants, especially the saline ones, are no more than anything else. And I'll see if I can get some information on that one too. Underwire bras. Why do you think underwire bras came under suspicion? Anybody?
Is the rubbing of the wires?
Yeah, it's irritation. So remember we were talking when we did head and neck, we were talking about irritation of badly fitting dentures, and that would be a causative factor for cancer. Well, this is what they're thinking is the irritation of, in some ladies that use the underwire bras. Makes sense, kind of. It has not been proven yet. This has been going on for at least 10 years or so, so nobody's said anything yet. Antiperspirants, again, there's no factors for this. Abortion, I'm not even going to get into the abortion problem, but there's been no research done on that. It's just someone.
What's the perceived connection there? I don't get that.
There is none.
Okay.
They think it may be something to do with the hormones,
Okay.
but as yet, nobody's proven it one way or the other, so.
I mean, if they're gonna take that leap, you could further it to like miscarriages, 'cause your
Yeah,
hormones,
exactly, and that
We're
doesn't
gonna draw the
hold,
line there.
that doesn't hold water at all, so, we want to make sure that, we're not hyping anything. And as I say, I'm not even going to get into the abortion debate of what should be or what shouldn't be, so, that is, they're still working on that. Whether anything will ever come to fruition on these things, I really don't know. Okay. Prevention. So not of Ashkenazi Jewish heritage. 2 first-degree relatives with breast cancer. 3 or more first or second-degree relatives diagnosed with breast cancer. A first-degree relative diagnosed with cancer in both breasts, or 2 or more first or second-degree relatives diagnosed with breast cancer, or a male relative with breast cancer. So first-degree relatives we get is mother or sister. What's a second-degree relative? Pardon? Grandmother, yeah.
Cousins? Or no? Okay.
Nah, not usually.
Aunts and uncles?
Aunts and uncles, perhaps, but only in the maternal line. So if you have a maternal aunt who had breast cancer, then you'd be more at risk than someone like myself who had a paternal aunt who had breast cancer. Because every time, you go in for a mammogram and they say, well, have you, and I said paternal aunt, oh, don't worry about it then. So, and as I think I said before, I once treated 3 members of the same family all at once. The daughter, the mother, and the grandma. And they were all on treatment at the same time. Grandma got diagnosed first. And then the mom, and then the daughter, the granddaughter. And a male relative with breast cancer. They're few and far between. You may never see a male breast cancer patient. If you're lucky, you might see 2. Lucky being. And unfortunately, male breast cancer patients tend to do badly because, well, you tell me, why might a male breast cancer patient do badly?
You get caught late.
Pardon?
You get caught late.
They get caught late. Why?
Because it's so uncommon that it's not really like
It's
the first
uncommon.
thing you do.
It's the last thing the guys ever think about. The women, we're cajoled and threatened and bombarded with this, you must go and get a mammogram, you must do your monthly breast exam, you must do this, you must do from the age of, whenever you can remember, that you have to go and do your mammograms, you have to go do this, you have to go do that. But the guys don't get that, as far as breast cancer is concerned. Prostate, yeah. Testes, maybe. But, so that's one thing. They're caught late because they don't think about it. Do they go for mammograms? Yeah, right. They don't go for mammograms.
I think it'd be very hard to do a mammogram on a male.
It has been known to happen. It's very difficult to do one, but it has been done.
I mean, would they go straight to like an ultrasound and then an MRI, or would they try to do the mammogram first?
They do a mammogram first. They go in and do the mammogram first. And it's difficult enough when you're a smaller lady or with smaller breasts. It can be a little more difficult to do one. Everybody knows how to do a mammogram? Yeah, it's actually this way. Yeah, that's okay. So basically, for those of you who doesn't know,
I mean, I've never had one.
okay, so basically what happens is that you have two plates. You go in and you have a machine, which is a sort of stanchion here, and then two plates that sit there. And you basically put the breast on one plate, and this other one comes down and squeezes.
Ow.
It's not really sore. It's a little uncomfortable, but it depends on what size you are. If you're small breasted, then it can be a little more uncomfortable. If you're large breasted, then that adds another problem because you are larger and it's more difficult to see. Then you have to press really hard. But it can be uncomfortable. It's not sore, it just is uncomfortable. So with the result that the males tend to be a little more difficult to, yeah. One of the times I went for a mammogram and there's this lady sitting next to me and she was at least 3 times my size, and I'm thinking, oh, the poor girl's trying to get this done. Anyway, yeah.
You need to do multiple mammograms just for one. Here.
So it is difficult to do the guys, and they don't even think about going for a mammogram. It's the last thing they ever think about. So how are most breast cancers found? Pardon?
Self-examination.
Okay, so hopefully you find them when you're doing a breast exam yourself. That's how most people find them in the shower, because you're soaping up and stuff. I had one young lady, well, she'd be mid-30s, I guess, and we were treating her. We said, just out of interest, how did you find it? Oh, I didn't find it. Oh, did you find it on mammogram? No. I said, okay, I'll get, my boyfriend found it. Okay.
Sorry.
So much for asking, yeah. So it's usually,
A lot of guys wouldn't even notice, they would feel it and just think it's another lump.
yeah. The best thing is to know what your breasts feel like normally. So if you are still menstruating, when should you not do your breast exam?
Right before your cycle.
Excuse me?
Before your cycle.
Before your cycle. Why? Because your breasts are swelling and sore and whatever. So pick a day after your cycle. If you already have had menopause, you just pick a day of the week or pick a day of the month. The local TV channel does one on the 12th, right? So go with that. So they do, to get back to the males, the problem is that because of the lack of mammograms and the lack of breast exams, and the fact that they're guys, they don't find the lumps until they're substantially bigger than they would if they were females. So they tend to go in late, and because they don't have a lot of fat usually, they tend to spread a lot faster because they're closer to the lymphatics. So they tend to be late. They tend to be they tend to be more aggressive. And that's because of the hormone problems. So where did we get to? Okay, male relative. Okay. So first degree relative with breast or ovarian cancer. Oh, and this is women of Ashkenazi. And 2 second degree relatives with the same side of the family with breast or ovarian cancer. So that would be your maternal aunt or your maternal grandmother. Okay, chemoprevention. NSAIDs. And everybody give me an example of NSAID. Non-steroidal anti-inflammatory drugs.
Advil?
Yep. Advil. Tamoxifen. Aromatase inhibitors. This one is the same as this one, slightly different, but this is the same type of thing. This is a hormone suppressor. It's actually a male hormone, tamoxifen. And they did a study not so long ago that if you give high risk women tamoxifen, then they go to a lower risk of breast cancer. However, tamoxifen does tend to give you a higher risk of ovarian cancer. So, prophylactic mastectomy. So mutated BRCA genes. If you have a BRCA history, you have to go through genetic testing to find out. So you find out that you have a BRCA gene, or you've had previous breast cancers, or you have a strong family history, or you have a biopsy specimen showing lobular carcinoma in situ, then you may decide to have what is called a prophylactic mastectomy. Somebody tell me what prophylactic means. Preventative, yeah. So you're basically, you know that you're at extremely high risk for breast cancer. So you do a mastectomy. And in BRCA cases, you may do both. You may do a bilateral mastectomy. And then you may do an oophorectomy, just what we were mentioning earlier. So at that, we will leave it and we'll go on to the other ones later. So